think what you're talking about is perhaps a fast fail type of endpoint, or an encouraging one. I think that has been a challenge given the need to for most of these agents to chronically dose it before you see an effect. Clearly you're aware of some of the dry eye chamber, which is an acute exacerbation of the condition, might offer an opportunity to see an effect in a shorter period of time. But the ideal model would be one that was validated in terms that it had predicted the activity of products that have been approved. But we only have one product that's been approved so far, so it's hard to, with a specific, that's very mechanism specific. So I think we still lack the tools to kind of get a quick read on, in kind of a clinical pharmacology read in screening compounds for dry eye syndrome. And as we heard, this is further complicated by the etiology of the disease and the fact that it's multifactorial, and small studies may really miss. You have to really make sure that you get the right patient, match the right subjects with the mechanism of action of your drug, and hopefully you know that well enough to do it. But early on, I think that's a challenge. Jerry?
I think with regard to proof of concept studies, would we do those as a first step? I think the answer is intuitively, all of us would move in that direction. As Dr. Dana said in one of his slides, if you have a pathway, and if you have the fundamental building blocks of things like PK and toxicology, a proof of concept study is the next step to take. It's also common sense. And I think those of you who are involved in drug development know that that's the way that most things go. You get a compound, you file an IND, and it's one of the things that's a positive about the FDA here in the U.S. is that you can work with the agency to get the right amount of data to have a limited clinical trial to test the proof of concept. And then you move into patients to see if your drug is effective. I think it's more complex, and it is clearly more perplexing in dry eye. And perhaps it is because we do not have that clear pathway that was one of the two legs that we mentioned a moment ago that forms the basis for moving ahead. Either that, or the patient population is so varied that we are trying to study that we cannot always find a cohort of patients who is similar enough to the group that we have studied previously in order to replicate the proof of concept study in a larger trial. And I frankly don't know which is the case, whether we don't have the right drug or whether we don't have the right patient base. But it's one of those two, perhaps a mixture of those two at some points. But I think that proof of concept studies have not shown to be as effective in dry eye trials as they have, for instance, in other diseases and other treatments in ophthalmology.
Yeah, I just wanted to add that I think it's very important to be careful of not doing too small a proof of concept studies, having a minimum number of patients per arm, whether that's 30 patients, 50, or 70. It probably is very dependent on the endpoint that you're studying. And just to give the drug enough chance to become effective. So whether it's a 1-week study or 3 months, it's important to match the mechanism of action to the trial design. And most importantly, from what we've seen, it's very important to make sure that your assessments are very precise, well controlled, that you're limiting the number of investigators that are doing the evaluations. And if you do this, then in hopes when you try to replicate the trial in the phase 3 program, you'll see what you saw in phase 2.
So the theory behind adaptive design trials is to do adaptive design trials in a indication population where you are not sure what the numbers are, you're not sure what the endpoints. Sound familiar? So the trial is designed taking the best guess at a number of different endpoints, picking a particular number of patients, and starting the trial and having an interim analysis somewhere along within the trial, and now adjusting the endpoints and adjusting the number of patients, either up or down, adapting the trial to what you find with your interim analysis. The agencies has repeatedly expressed publicly that that is perfectly fine to do as for hypothesis generating. So you do that type of trial, you adjust the endpoints, you adjust the numbers, and you come up with now your hypothesis, which then needs to be run into additional trials. That type of alteration in trial design is a learning process and is not a definitive answer for whether a product is safe and efficacious. And so it is frequently proposed to us that that people want to do an adaptive trial design and count that as one of the trials that shows safety and efficacy ultimately toward approval. And we repeatedly say that's good for hypothesis generating, use it, figure out what your endpoint should be, and then plan your definitive trials.